Laryngeal Papillomatosis, also known as Recurrent Respiratory Papillomatosis. Laryngeal Papillomatosis, then the newer terminology is Recurrent Respiratory Papillomatosis, and this is the most common benign neoplasm in childhood. Benign laryngeal neoplasm in children. And so we will go through the etiology of LP, pathophysiology, the clinical features, the diagnosis and treatment modalities. Okay. So this laryngeal papillomatosis, as a name suggests, it can happen anywhere in the respiratory tract from the nasal vestibule up to the terminal bronchiole. And this, as a name suggests, this is recurrent also. So recurrent respiratory papillomatosis, and there are two varieties. One is childhood onset or juvenile, and the adult one is another one is adult onset. Okay, so childhood onset papillomatosis and also adult onset respiratory papillomatosis. Childhood onset is more aggressive form. This causes more chance of airway obstruction because it spread to multiple sites. So airway obstruction chance is very high. It can spread to multiple areas. Usually this respiratory papillomatosis, as I already told, it can happen or it can occur from nasal vestibule up to the terminal bronchiole. But the predominant sites are where the squamous epithelium changes to ciliated columnar epithelium. And they are mainly the uvula, then the tonsillar pillars, then the vocal fold and also the anterior commissure. These are the predominant sites where the squamous epithelium changes to ciliated columnar epithelium. Okay, so all these sites are more, this childhood onset is more predilection for multiple sites. And also the chance of recurrence is more with the childhood type or juvenile onset, and because there is chance of recurrence or it recurs very fast, there will be multiple surgical intervention in the case of childhood than the adult onset. And adult onset can also be aggressive, and that depends upon the subtype of human papilloma virus. So these are the main difference between a childhood onset and adult onset, and all the other modality or other headings are almost the same in both types. And coming to the etiology of RRP, it was a person called Morel Mackenzie who first described this juvenile onset respiratory papilloma in 1880. The exact mechanism of spread and cause of this one is unknown, but there are, as if something is unknown, we usually give so many postulates. So one is human papilloma virus, and usually associated is 6 and 11, but in some cases there is also 16 and 18, and the 16 and 18 are associated with the carcinogenesis. Okay, so usually most common association is HPV 6 and 11, and this 11 has got a more aggressive form than that of 6. Okay, and another one is especially in childhood onset. One is human papilloma and second is vertical transmission during childbirth. Because the risk factors are primary gravida, firstborn child, and also recently acquired genital wart. So the risk factors for this vertical transmission are the primary gravida, firstborn child, and recently acquired genital wart. And the incidence in children is 4.3 per 1 lakh childbirth. Okay, and that of adult onset, the most common cause is found to be oral sex, and also there was a study conducted by Kashima et al., and they found that there is a high amount of this viral particles in the fumes, that is after the laser surgery. So the surgeon performing the laser surgery should be aware of this, and they should use protective equipments. So these two are, oral sex is the most common cause of adult onset respiratory papillomatosis. Okay, then what is the pathophysiology? Enormous amount of research is going on this laryngeal papillomatosis, but they have not reached any consensus, so that we can't give an exact drug for cure. And the suggested is, this is happening in the aerodigestive tract squamous mucosa, that you know. So in the basal layer of this squamous mucosa, there are stem cells and there is infection of the stem cells. That's human papilloma virus will come and infect the stem cell, and this will lead to alteration in the epidermal growth factor receptor pathway. So that is thought to be the pathophysiology of this respiratory papillomatosis. Okay, so the stem cells are infected which are lying in the basal layer of the aerodigestive tract squamous mucosa. That will lead to epidermal growth factor receptor pathway alterations. And what will be the histopathology? It will be like there will be proliferation of the stratified squamous epithelium. There will be proliferation with a central fibrovascular core. Okay, this will be the microscopic appearance. There will be multiple proliferation of the stratified squamous epithelium with a central fibrovascular core in between. So that is it. And coming to the clinical features, as the primary site is in the larynx, hoarseness or the change in voice will be the first symptom, or can be present as stridor also. And in adult, the most common presentation is either hoarseness or a chronic cough. And there will be recurrent attacks of choking spells or a recurrent respiratory infection and failure to thrive in children. So there is high chance of misdiagnosis as bronchial asthma, or you can misdiagnose it for laryngitis, or it can be misdiagnosed as bronchitis or as a croup. Okay, so all this has to be kept in mind while you come to a patient with the clinical features of this. And the diagnosis is mainly by a careful history, examination and some investigations. So first thing is careful history taking. What are things you have to ask in history? Take a detailed history in this case, especially ask for any history of intubation, then a thorough perinatal history, and how the symptoms start, what is the onset, and if there is any progression of the symptoms, history of any trauma and history of any voice change. And also you ask for associated symptoms. Like what? Associated symptoms like feeding difficulty, history of allergic rhinitis, history of vocal abuse, and also history of reflux irritation. All these has to be asked in history so that you will get with the other differential diagnosis. Okay, so history is very important. And the second is examination. And in the examination, mainly look for tachypnea, then presence of stridor. And if there is stridor, look whether it is changing with the position of the patient. And also evaluate the speech and the cry, and also the use of accessory muscles. All these thorough examination of all this is important. Then comes the investigations. What are the investigations to be done? In the investigation, a flexible fiber optic nasopharyngoscope is very good, and this will give you a precise preoperative diagnosis and also will help you to rule out other differential diagnosis. And this papilloma will appear as pinkish to white grape-like projection, which can be either sessile or pedungulated with a central vascular core. So it will be like a clear grape with a visible seed. This will be the appearance. Clear grape with a visible seed. Pinkish to white, sessile or pedungulated, grape-like projections. In the above said, I already told the most predominant site. And also stroboscopy will be helpful. Another one important investigation is a narrow band imaging. And this narrow band imaging will use a short wavelength blue light which is absorbed by hemoglobin. And since this papilloma has got a very vascular core, the narrow band imaging will give a bluish dot with the surrounding whitish areas. Okay, so that is a usefulness of this narrow band imaging. And biopsy with HPV typing is the gold standard in the diagnosis. And what is the role of radiology? Radiology is not of much help, But CT scan can be done in a case of recurrent disease or in a case of pulmonary papilloma, where you want to find out the exact site of lesion. Okay, so these are the investigations. Going to the treatment, we will go through the staging also. That is, accepted one is a Derke staging. This is not universally done. Even in centers where there is high amount of clinical material, this staging is not done, and this is mainly for the purpose of research, especially for a multi-centric trials. So the 4 score, 0 is none, 1 is a surface lesion, 2 is a raised lesion, and 3 is bulky lesion, and depending upon the subsites. So it can be in the larynx, trachea or others. In the larynx it is for epiglottis, then arytenoids, then epiglottic fold. If it is present, you give this either 0, 1, 2 or 3 depending upon the morphology of the lesion. Then true chord, also there is a false chord, then anterior commissure, posterior commissure and subglottis. These are the subsites given. And in the trachea, upper 1/3, lower 1/3, middle 1/3, then bronchus, both right and left. Also right and left, and also the tracheostomy stoma. Then in the nose, others, it comes nose, palate, pharynx, esophagus and others. And you have to give a total score also. So this is mainly for the postgraduate residents should know this. You should be aware of this staging system. That is why I told, and this is of no clinical importance. Clinically we are not using this. Okay. Next, in the treatment, the aim of treatment is removal of this papilloma, restoration of a safe and patent airway while minimizing injury to the mucosa and also to the vocal cords. So there are multiple modalities, but the gold standard used is a surgery itself. Okay, so we will go through the treatment options. So in the treatment modality, as I already told, surgery is a gold standard with minimal trauma to the normal tissue. So for that, a suspension microlaryngoscope and removal using laser is preferred, and carbon dioxide laser is generally used, but you can also use a KTP laser or Nd:YAG. But as per 8th edition Scott Brown textbook of otolaryngology, which is a standard textbook for the residents, Microdebrider assisted removal is preferred choice, and in that also you have to use a non-serrated laryngeal blade with 300 to 700 RPM. The advantages told are, one, you are doing it under endoscopic control, and there is a suction incorporated, so this will suck the blood so that the blood will not go to the lower airway, and as it is under endoscopic control, very precise removal can be done and injury to the normal tissue is avoided. What will happen if there is injury to the normal tissue while removing a papilloma? We are creating, after injury, we are creating the squamo-columnar junctions. Okay, so iatrogenic squamo-columnar junctions will be created. So all in that area, this papilloma, deactivated papilloma will get activated in this area. So the further implantation and growth of papilloma will occur. So you have to avoid maximum avoidance of injury to the normal tissue. For that, Microdebrider is preferred than carbon dioxide laser as per Scott Brown textbook 8th edition. And also there is no thermal trauma in case of a Microdebrider. Can you use coblator and cold instruments? Coblator you can use, but very limited data, and cold instrument, the main disadvantage is chance of injury to the normal tissue, and also if there is also chance of bleeding which can go to the lower airway, can contaminate the lower airway, and also there can be iatrogenic squamo-columnar junctions where there is chance of recurrence of the papilloma. So Microdebrider assisted or carbon dioxide laser assisted suspension microlaryngoscopy is, or under endoscopic control, is a preferred choice in a case of surgical removal of RRP. These are the indications for adjuvant therapy, that is more than 4 surgeries per year, or rapid regrowth of papilloma, or airway compromise and or distal multi-site spread. These are the indications for adjuvant therapy. And the adjuvant used are, one is cidofovir. This is highly recommended one by the task force. Intralesional injection of cidofovir is a pro-drug. It will incorporate with the DNA and this will deactivate the papilloma virus. Okay. Also you can use photodynamic therapy. Then bevacizumab can be used, interferons can be used, indole 3 carbinol can be used, and also proton pump inhibitors. So all these are the adjuvant therapy, and of this cidofovir intralesional injection is highly preferred. And after surgery, the specimen has to be sent for histopathological examination because there can be a misdiagnosis or differential diagnosis include verrucous carcinoma, squamous cell carcinoma, or a vocal cord leukoplakia, and also carcinoma in situ or a carcinomatous change can happen. So always, even if you are doing multiple times, at every time biopsy has to be sent for an detailed histopathological examination and HPV typing. Okay. Chance of malignant transformation of laryngeal papilloma is more common with an adult onset type. Okay, so this is all regarding a recurrent respiratory papillomatosis.